Hi guys, welcome to my channel Dr. Z, the AIIMSified WombWhisper. Today I'll be teaching you about obstetric history taking. This is the most important class as per me, this obstetric history taking and then the obstetric examination, as you should know how to take a case, whether you are seeing a patient in OPD or you are doing a workup of the patient of ANC patient in ward, because from history you will know about what the patient is, what are her risk factors, how to go about her pregnancy, how to manage her, how to monitor her, what complications she is expected to have from her history only. And after doing examination, then you formulate the plan of management for the patient. So for that you should know obstetric history in and out, what points to be asked, what uh, what are the important points in like HOPI or menstrual history or obs history or personal history. So you should be knowing this with heart. So there are some general principles before you start taking proper history. First, it should be in patient's language. you know Most of the patient may not be educated, they may be coming from periphery, or low socioeconomic background or not so educated background. So it is always important to have a conversation in patient language and ask about the some medical terms in patient's language only. And you should give patient the satisfaction that okay, she is being heard, her problems are being answered, we are properly understanding her concerns and problems. So you should ensure privacy and you should build rapport, you should be gentle, and you should always be welcoming and listening to what patient is telling you. And you should ask mostly open-ended question. Sometimes when patient is not able to understand your question or like some points, then we can ask some leading question, but mostly it is open ended question only. And we should always be respectful and we should avoid any judgment about patient, okay, be it socioeconomic background or education or any other thing. So first thing is patient details. So you ask about, so these are the points like name, age, duration of marriage, husband's name and occupation, and further. So I'll just talk about one point and why is it important. Whatever you are asking the patient, it is very important. So you should know why we are asking the name of the patient, because if we call the patient by name, so there is a sense of like bond and rapport. So we should always ask about the name of the patient. We cannot call her okay this patient, that patient, or we cannot call the patient by this word patient in while we are talking with our colleagues also, like this patient had this thing. So we should always say okay, Mrs. X or Mrs. Y has this problem, so she is being admitted. So we should always know about the name of the patient and we should call her by name only. Second is age. Why age is important? Because extremes of age leads to many complications, be it like teenage pregnancy or elderly pregnancy. When do we call patient as elderly gravida? If the first pregnancy is after 30 or 35 years as per FIGO, then we call the patient as elderly prime gravida. If the first pregnancy is conceived at that age, and if the pregnancy has been conceived at less than 19 years of age, then we call that pregnancy a teenage pregnancy. Why? Because teenage pregnancy may lead to hypertension, anemia, malnutrition, FGR. These are the complications of teenage pregnancy. And similarly, elderly primary gravida have her own complications like GDM, hypertension, PPH, FGR. So these are the complications of elderly primary gravida. Why duration of marriage is important? Because from the duration of marriage we can know about the fertility or fecundity of the patient. So what is fecundity? Fecundity can be low or it can be high. When do you call a patient having low fecundity? When a pregnancy is being conceived after marriage without taking any recourse to any method of contraception, and if it is conceived soon after marriage, it is called high fecundity. If a patient is suppose she is married only for 6 months and she had not had any contraception and she conceived spontaneously, it is called pregnancy with high fecundity. And when a patient has been suppose the marriage is of 3 or 4 years and she was not using any contraception and she was trying for contraception since long 3 years and she has conceived after 3 years, so it is of low fecundity. Okay, and a women with low fecundity is unlikely to conceive frequently. It means our fertility potential is low, so we should know the duration of marriage. Next, husband's name and occupation is important because from husband's occupation you can know about the socio-economic background of the patient. And why socio-economic background is important? Because suppose patient is of anemia or malnutrition, so we tell patient to consume high protein diet or like protein biscuits like peptin or protein powder, and we tell patient to consume iron rich foods which can be fruits, vegetables, jaggeries and dairy products. So all these may consume money, everything cannot be free in government settings. So socio-economic background is important, and also about to give reasonable and realistic antenatal advice during family planning guidance. Okay. Address is of importance because like some patient may belong to some endemic areas where a disease is common, like in eastern part of India, West Bengal, Jharkhand, Bihar, where Kalazar is common. So patient may be coming from that area. So if she comes with complaint of fever or anything, we should have a suspicion of the endemicity of the area from where she is coming from, and also to know if she lives nearer or far by from the hospital. So if she is living far by and she is a high risk patient, so in that case mostly we admit the patient to manage her condition, and we tell the patient to have an attendant always with her even in home, and we always explain the patient about the high risk, like if she is a case of suppose transverse slide or a monochorionic twin pregnancy, so she can have like rupture of membrane and there may be cord prolapse. So we always explain the patient to live nearby to the hospital, so as soon as rupture occurs she just directly comes to hospital within minutes. So it is of importance, nearness to the hospital is very important, and if the patient is living in high altitude there is hypoxia which may lead to IUGR of the baby. Education is important. Similarly, we explain the patient always now when she comes for ANC visit, okay, she has to take this medication at this time. Why physiological anemia or nutritional anemia is so common in ANC patient? Because they don't, most of the time doctors also don't explain properly, and when explained properly patient cannot understand most of the times, which may lead to intake of iron and calcium simultaneously or at wrong times, and which ultimately leads to anemia. So in understanding medication, when we counsel the patient about any high risk, or suppose in diabetes we counsel the patient about diet or exercise, so educational background is important to understand the counseling also, and we explain her how to have ANC visits like 4 weekly, 2 weekly, 1 weekly. Occupation, similarly, if patient is suppose heavy weightlifter, we tell her to avoid so much weightlifting during like third trimester, or when she had like threatened abortion, we tell her to avoid strenuous activities. And if she has sedentary job, then there is risk of GDing. If she has exposure to radiation and teratogenic drugs, like she is working in an environment where there is use of radiation or there is use of teratogenic drugs, so knowing the occupation is important to make the patient understand to avoid these things, so as to avoid any complication in her pregnancy. And also it is important to know the occupation of the patient, because some medications which are not available for free in government college, so we may need to tell her to buy medicine. So we should know if patient can afford those medicine or not. If not, then we think about an alternative cheaper medicine. So it's important. And also if patient doing any excessive physical work, she may get fatigue or any stressful work, so we should be telling her to avoid those work. Similarly, socioeconomic condition will tell about low anemia, if the socioeconomic condition is low, like she belongs to lower middle class or low economic group, then there is risk of anemia and malnutrition, which will subsequently lead to low weight gain in pregnancy, leading to IUGR. And if the BMI is high, mostly socioeconomic condition, patient may eat whatever she like at any time. There may be overeating, which may lead to GDM, hypertension. And we should ask about obstetrics. We should mention about obstetric score, her LMP, estimated delivery date, and PUG in history itself. Okay. And how to calculate, how to date a pregnancy. We use Naegele's formula. From LMP we add 9 months plus 7 days, then we get estimated delivery date. And POG is important. Why? Because we should know at what POG we are taking the history from the patient. If suppose she is in first trimester, then obviously I won't take history of leaking PV or decreased fetal movement, because she won't be feeling it. And suppose if she is in third trimester, then I should know she may be having raised blood pressure or pedal edema or any other signs, symptoms of preeclampsia, leaking PV, bleeding PV. So knowing at which gestation the patient is currently in is very important to take the relevant history. So here I have mentioned the same thing, how to calculate the period of gestation and estimated date of delivery. In some patients, when we ask about LMP, like last menstrual period, and then we do 9 months plus 7 days, patient should have regular cycle before that. So to have an accurate dating, if her cycles were irregular, we may have inaccurate dating. So what do you mean by regular menstrual cycle? At least you should have normal menses at least for 3 months before conceiving. Means she should have regular cycles for at least 3 months before conceiving. And in cases where patient may not know, most of the patient sometimes just come and she tells that she does not remember her cycles accurately because her cycles are very irregular, and she cannot recall the LMP, or maybe she was taking OCPs for contraception and then she stopped because she wanted to conceive and then she has conceived. So in that case the LMP may not be reliable, and then we use other methods of dating like ultrasound scan. Okay. And in case of IVF pregnancy, what we do is we add 14 days, means 2 weeks to the date of embryo transfer. We take the date of embryo transfer and then we calculate the EDD from there and add 2 weeks to the EDD, which give us the actual thing. Okay. So suppose currently from ET her period of gestation is coming to be 32 weeks, but actual her period of gestation is 32 plus 2 weeks, that is 34 weeks. So for IVF pregnancy we calculate like this, we add 2 weeks to the period of gestation and to the EDD. Okay. And we should know when she has been admitted and when we are examining the patient. And chief complaint of the patient. Chief complaint of the patient should be in patient's language. Okay. And in chronological order. You may ask her what has brought her to the OPD, why she has come to OPD, or if you are taking history in a ward, you will ask her why she has been admitted in the ward. Okay. And the sequence of complaint is important, like which complaint has occurred earlier will be coming earlier. She may have 10 complaints, but you should be writing 2 or 3 main complaints in chronological order. For example, when you are writing the chief complaint, you may start writing as she is gravida 3, para 2 with 2 living issue at 30 weeks period of gestation with previous 2 NVD presented for routine antenatal visit. If you are taking a patient in OPD only, so patient may not have any comorbidities, maybe she has come for routine antenatal checkup, so you mention it like that. Like sometimes we write chief complaint, patient presented to OPD for routine antenatal checkup. So there is this one way of writing and there is this better way of writing, like gravida 3 para 2 living 2 at 30 weeks period of gestation with previous to NVD for routine antenatal checkup. There is another example like gravida 2 para 1 live 1 36 weeks period of gestation with previous one full term LSCS. If there is some significant obs finding like with from previous obs history, you can mention it earlier so that the examiner may know the severity of the case or the importance of your case. With chronic hypertension presented to OPD with increased home blood pressure records, or patient is priming gravida at 37 weeks period of gestation with fetal movement. So complaint can be anything, and it's better if you present like this. Presenting like this is not wrong, but it's better if you present like this. It will emphasize your finding, and examiner they will know, okay, a patient is this, what are the risk factors and why she has presented. When you are telling chronic hypertension with home blood pressure records, then the examiner will know, okay, the patient was being monitored and she has come and there is something wrong with her BP, so she is being admitted. HOPI, it is very important. HOPI, in any OBS case this will change only, and mostly the other headings like patient details, trimester history, past history, menstrual history, OBS history are all same, only this will change. So you have to elaborate the chief complaint in details, and you should mention relevant negative history and how the patient has been managed further till now, till the date you are taking history. Like the patient is of chronic hypertension. So suppose the patient presented to OPD with raised BP records, and she was on certain medication, maybe the dose was inadequate, so her BP was not managed on those medication, and then the patient was admitted. So you should mention what problems patient had, only raised BP or any other symptoms of preeclampsia, and then you should mention the relevant negative history, and then like why she is being admitted, her medication has been changed or not, and what further actions you have taken, how you have done further maternal or fetal monitoring. All you should mention in history of present illness. So here I have given an example of raised BP record patient. It can be any other like deranged blood sugar record or decreased fetal movement or pain abdomen or leaking PV. So it will come with subsequent case discussion classes. Here I have just given one example so you can know how to write the case. Okay. So read gravida 2 para 1 live 1 at 36 weeks period of gestation. Previous one full term LSCs. You can mention it or leave it also, does not matter much, but it is better if you like give in more details. With chronic hypertension presented to OPD with increased home BP records. Patient is a known case of chronic hypertension since 2 years. She was currently on oral antihypertensive. If patient can mention the name of the drug, you can mention it here like tablet labetalol, or if she cannot mention, she can only say like she is taking some medication for 2 times a day, you just mention it like that, oral medication, which she was taking twice a day, on which her BP was controlled, but now she has presented to OPD with increased home BP record. If patient is able to tell the reading, you mention the reading. At OPD visit, her BP was found to be this much, but now you give the relevant positive and negative history. This patient had no complaint of headache, blurring of vision, epigastric pain, right upper quadrant pain, swelling of limbs, chest pain, nausea, vomiting. In OPD itself, since the BP was this much, you had to manage it in OPD first. Now you cannot just leave this patient and send her, okay, you go to labor room. That may take time. You need to reduce the BP then only. So, and the first medication is oral medication always. So in OPD itself, you have given her oral drugs, 2 tablets, following which her BP was controlled and she was admitted in ward for fetal and maternal monitoring. Okay. So this is how you will write history of present illness if a patient is of like high BP records. And if patient presents with pain abdomen, what will you take in negative history? Pain abdomen can be due to leaking PV. If there is PPROM, then there may be preterm labor. So in that case there may be pain. If there is APH like placenta abruption or something, there may be pain abdomen. In UTI symptoms also there may be pain abdomen. So relating to her symptoms, you should know what negative history you should be taking, and you take that in that way only. Now history of present pregnancy. So you take it trimester wise, first trimester, second trimester and third trimester, and there is a format. Okay, you should be taking in this format, so it's better to learn one format and go with that for every case discussion or any ward workup. Okay, in first trimester it is very important to know if the conception was spontaneous or assisted, if it was planned pregnancy, because if it was planned, patient must be taking preconceptional folic acid, and if it was unplanned, she may have missed the preconceptional folic acid. If there was any change of drugs, if the patient, suppose if the patient was of chronic hypertension, she may had been on telmisartan or anything else, but we don't continue telmisartan in pregnancy. Why? Because it is contraindicated and teratogenic, so change of drug is needed. So if the pregnancy is planned, patient may have changed the drug at first only. So it is important to note if there was any change of drugs or if there was any weight loss. Suppose if the patient's BMI was high in preconception period, then we always tell the patient to optimize her BMI before conception, so as to reduce her risk of GDM or hypertension. If patient had addiction of smoking or alcohol, we also tell patient to stop taking alcohol or to smoke. So all these are important to note. If any corrective surgery was done, if a patient was of heart disease, we tell the patient to do corrective surgery before conception. So all these are important to note. If there was a history of periconceptional folic acid, if patient had taken folic acid like 1 month or 3 months before conception, if not, then when she had started taking, only after being UPT positive or doing the ultrasound or having her first visit only, then she had started taking. So you should be noting when she diagnosed pregnancy, when her UPT was positive, like after 1 week of missed period or after 10 days of missed period, you should be noting when she had her first ANC visit, or if she was booked somewhere at any hospital previously or in this hospital only where you are taking the history. If any dating scan was done, it is the first scan which is done, and from this you can correlate the dates from LMP also. Okay. And if any investigations was done, normally in any first visit we write basic antenatal routine investigation, and if that was normal or not, patient always tell that some reports were done which were normal, so you should be noting that. Patient may not tell NTNB scan or dual marker, so how to ask? You will ask like, if any ultrasound was done at 3rd month of pregnancy, following which one expensive blood test was done. So if patient tells yeah that was done and report was told to be normal, so you should be mentioning like another ultrasound was done at 3rd month of pregnancy and which was told to be normal, and following which another blood test, expensive blood test was done which was also normal as per patient. Okay, and you should be asking about any complications of first trimester like excessive nausea or vomiting, if there was any bleeding PV which may indicate abortion, threatened abortion, if there was any fever with or without rash. Why? Because there may be some torch infection which may transmit and lead to congenital anomalies. So it is very important to take history of fever also in first trimester, because the organogenesis is in first trimester. Okay. If there is exposure to any teratogenic drug or radiation exposure, and history of COVID vaccination you can take here or in personal history. Okay. In second trimester you should be asking if patient is taking iron and calcium tablets regularly or not. If she has taken tetanus vaccination, normally primary patient we give first dose of tetanus at first visit only, but most of the patients they may not present in at 3rd month or so they may present late. So you should always ask about history of tetanus vaccination. Then if any ultrasound was done at 5th month of pregnancy and baby's structures were told to be normal to her, you ask in that way. If the dual marker was not done in first trimester, then another anomaly marker or aneuploidy marker was done in second trimester or not, which indicates quadruple marker. You should not be mentioning like dual or quadruple, you should mention like some expensive blood test was done which was told to be normal, or blood test was not done. You just mention that, and when examiner asks you, okay, what do you think the scan may be at first, at 5th month of gestation, then you should tell that maybe level 2 scan which was done, for any congenital anomalies there or not, to see that. And what may be the blood test following that, you may tell it may be quadruple marker, or what may be the blood test following 3rd month scan, you may tell it may be dual marker, for aneuploidy screening, like most common is Down syndrome. Okay. You should ask about when patient has failed quickening. Mostly in primary gravida they failed it around 18 to 20 weeks, like 5th month gestation, and in multigravida they may feel it as quick as 16 weeks, like 4th month gestation. And about if any sugar test was done or not. Normally Indian government, like Ministry of Health and Foreign and Family Welfare, they say to do DIPSI at first visit only. Why? Because here there is no need of any fasting. Patient may not return to you, and and since India is the diabetic capital, so we should screen all the patient. And what we do in DIPSI, we give 75 gram oral glucose to the patient irrespective of her fasting status, and after 2 hours we check the blood sugar, and if the value is more than 140 milligram per dl, then she is labeled as gestational diabetes mellitus. Okay. And other guidelines like WHO or Indian Association of Diabetes in Pregnancy group, they recommend OGDT. For that we need fasting status, that I will talk in details when I teach the diabetes in pregnancy. Either of this can be done, and we should ask patient if this has been done or not. You should ask about weight gain in 2nd and 3rd trimester also. So here I asked about how much weight she has gained. A normal BMI patient should gain weight, how much, and all this I will teach in basic antenatal care class. Okay. So ideally there should be 7 to 11 kg weight gain in pregnancy. And how is the breakdown, I will teach you later. You should ask the patient how many total ANC visits she had in 1st, 2nd and 3rd trimester, like how we follow the patient. Normally at least 4 ANC visits should be there. Ideally WHO says that there should be 8 visits, but what we follow here is 12 to 15 visits at least. How? Up to 28 weeks we call the patient 4 weekly, then up to 36 weeks we call the patient 2 weekly, and after 36 weeks we call patient weekly. Okay. So this is how the total number of visits comes to 12 to 15. And you should ask about any complications in pregnancy, like preeclampsia, gestational diabetes mellitus, nutrition, physiological anemia. All these are common in 2nd trimester. So you should ask about if she had any high BP records during her, the last ANC visits, or she had any vaginal discharge or UTI symptoms or bleeding PV. Okay. Now 3rd trimester, iron and calcium tablets, if she is taking it regularly or she is being compliant to it or not, if she had any anemia or not, if the dose of iron tablets has been increased or not. And in 3rd trimester we do fetal growth scan. So you ask her if any fetal growth scan was done or not in 3rd trimester. Okay. Total number of ANC visits, total weight gain, and like similarly history of high BP record, any itching over palm, soles and body. What do I want to know from this? IHCP, intrahepatic cholestasis of pregnancy, which is most common in 3rd trimester, and it is seen in many patients. And if there is any history of bleeding PV, leaking PV, any decreased fetal movement or any pain abdomen, you should be asking about this. Now in menstrual history you ask about the age at menarche, how were her cycles, if it was regular, how was the length, how was the flow, because if she had heavy menstrual bleeding, then there is probability that patient may be anemic. So we should know about how was the flow. if she was using any hormonal contraceptive, if she was a case of PCOD, because if she had been a case of PCOD, there may be delay in ovulation, and then LMP can be unreliable. In OBS history, there is a format. First, you ask for how long she is being married, if the marriage is consanguineous or non-consanguineous, because if it is consanguineous, and there is more chances of genetic anomaly, a genetic abnormality in the baby. You ask about the OBS score, you write it like this, mostly gravida status and then parity status. What is gravida? The number of times patient had been pregnant, be it ectopic pregnancy or normal intrauterine pregnancy, whatever, or abortion also. And parity, the number of time patient's pregnancy has crossed the period of viability. And the period of viability is different in different countries. Like in ACOG, it is around 22 weeks. RCOG take it as around 24 weeks. In India, the period of gestation is not set, but we also it is like institutional, like AIIMS Delhi. If the baby is more than 24 weeks or more than 500 gram, then there is possibility of the baby being viable, and we take every chance to keep the baby viable and alive if it crosses this much gestation or weight. So what is the format? If patient had a live pregnancy, like suppose this para 1 live 1, this patient had one live pregnancy, so you should note the year she was pregnant, and then if the pregnancy was spontaneous or assisted, if she had any antenatal complication, because there are some antenatal complication which if it was present in earlier pregnancy, it can recur in the next pregnancy, like anemia, hypertension, GDM, APH, all these recur in subsequent pregnancies also. So we should be knowing this. If she had any FGR or malpresentation, preterm labor or PPROM, if her intrapartum period was eventful or uneventful, what was the type of delivery, if it was normal delivery or cesarean section, how was her labor, if it was prolonged or precipitate labor. You may ask patient for how long she was into labor. If cesarean was done, what was the indication, because suppose if it was done for contracted pelvis, then again cesarean will be done only. But if it was done for non-recurrent reasons, like breach or like macrosomia, then there may be a chance that we can give patient Tolac if the condition is not there again. Okay. And if there was instrumental delivery, then what was the reason? There may be maternal exhaustion or fetal distress or anything. And if there was any perineal tear, like 3rd degree, 4th degree, if there was any PPH, if she required any blood transfusion, then you ask about the baby. If the baby cried after birth, what was the sex, what was the weight of the baby, if the baby is currently well and alive, has received immunization or not. So you ask about all this. And then about the postpartum period, if it was eventful or uneventful, if she had fever, UTI, anemia, or any sign symptoms of puerperal sepsis, mastitis or anything, you should be asking about that only. So this is the format. You start with conception, then antenatal, then intrapartum, then postnatal, and about baby also. Similarly, if she had previous IUD, so you ask about the year, spontaneous or assisted conception, then antenatally, because IUD, first IUD, there may not be any reason, but if there is recurrent IUD, then we should always find out the reason why the IUD is occurring. So there are some conditions which may lead to sudden IUD, and patient may not be diagnosed of any condition in the pregnancy, in the first pregnancy. Like you should ask if there was history of raised BP record, or her blood sugars were very deranged, if she had any APH, antepartum bleeding, or FGR or malpresentation, and cord prolapse, IHCP. In IHCP there is chances of stillbirth, so you should be asking about all this condition. Similarly, intrapartum, if it was term, preterm, if there was any prolonged labor, if cesarean was done, what was the indication. Similarly, in IUD baby, you should always ask about when the baby was born, what was the condition of the baby. was it like the normal fresh baby, or the skin were macerated or skin peeling was there, which may indicate old IUD. So you should be asking about that, if there was any congenital malformation in the baby or not, if autopsy was done or not, any genetic testing was done or not for the baby. You should be asking that also. And similarly, postpartum period, eventful or uneventful. And after each delivery, if patient had taken any contraception or not, you should be asking that also. Similarly, for cases of abortion, what should be your format? Year, conception, whether spontaneous or assisted, whether if it was first trimester or second trimester abortion, because first trimester abortion are mostly due to chromosomal anomalies and second trimester are mostly due to cervical insufficiency. At what period of amenorrhea or gestation was the abortion done, or it was spontaneous? If the abortion was recurrent, like 3 abortion had been recurrent, thrice she had abortion. If UPT was done, or just before doing UPT only she had bleeding. If UPT done, then was it positive? If ultrasound was done, had it shown cardiac activity or not? If the abortion was spontaneous, like after doing ultrasound there was cardiac activity, then suddenly bleeding occurred, then that is spontaneous abortion. Or like ultrasound was done, there was no cardiac activity, and again after 1 or 2 weeks she did ultrasound and still no cardiac activity was there. So was it missed abortion, or she took MTP pills herself because she did not wanted pregnancy? You should be asking that. If the abortion was managed with medicines only, or she required evacuation, dilatation and evacuation, or surgical evacuation, and whether her blood group was positive or negative. If negative, then did she received any anti-D injection or any expensive injection or not? Patient may not be knowing anti-D injection, so did she receive any expensive injection or not? You should be asking that for negative blood group. And what should be the minimum gap between 2 conception? Ideally it should be 2 years. Okay. In past history, you ask about some chronic condition like hypertension, diabetes, thyroid disorder, asthma, heart disease, epilepsy, TB, because all these conditions may lead to some or other complication in the pregnancy, and this should be managed well, otherwise it is harmful for both the mother and the baby. If she had any history of surgeries in past, like myomectomy, if she had myomectomy, if cavity was opened, then she had full thickness scar, there is chances of scar rupture. If she had previous LSCS, that too you should be asking in obs history itself. If she had any laparotomy, then there is risk of adhesions intra-abdominal, and while you are going for cesarean for this patient in this pregnancy, you may encounter adhesions, or there may be like bowel injury also. So you should be knowing about the surgeries she had in past, and if there is any history of blood transfusion or ICU admission, any complications in past. These two is additional in gynae and obs patients, like history of cervical cancer screening, if she had any pap smear screening or any vaccination for cervical cancer prevention, you should be asking these also. In family history, history of twins is important in family because it may recur in the patient itself. History of genetic condition is important, and consanguinity. Okay. And any history of chronic medical disorder, TB, hypertension, diabetes in mother, father, or first degree relative or siblings itself. In personal history, like in medicine and surgery, sleep appetite, bowel bladder habits, if she is taking any current medication and for how long she has been taking the medication, if any allergy to iron, or sometimes patient may have allergic reaction to iron, so you should be asking about any allergy to any kind of drugs or dust or anything, or any kind of food. If she had any drug reaction in the past, many patients are allergic to NSAIDs, so we should be knowing it, because in pregnancy or in postpartum period we may prescribe NSAIDs to the patient for pain relief, so we should be knowing it beforehand if she had any past allergic reaction to those medication, commonly used medication. And if she had any addiction, And dietary history you should also be asking. You should know the basic calorie requirement of the AIIMSi patients according to her BMI, and if she is taking the the dedicated calories in her diet or not. Because if the diet is less, if she is taking less calories as per her requirements, then there is risk of malnutrition and subsequent FGR in the baby. Okay, so dietary history is important. And then the summary. So after all these points you come to the summary. Before starting examination you should be telling a short summary relevant to the history you have taken. So here my patient, I am giving just an example. Mrs. X, 30 years old, she is gravida 3, parity 1 with 1 living issue and 1 previous abortion at 37 weeks period of gestation with previous 1 cesarean section, and with complaint of decreased fetal movement since last 1 day, booked at PHC. So this is the basic summary of after history, and after that you start with examination. Examination I'll take up in next class because that is also a huge part, and that should be discussed in detail. So I'll keep this video shorter with this only. So I hope I am being able to make you understand about why history is important and how you should be taking it, about importance of each point we are taking in history. And if you have any doubt or question, you can surely ask me in comment section, or if you think this point was wrong in my teaching, or this could be better, or this can be that, you can also tell me that in comment section. And so thank you for listening to me. Please subscribe to the channel so I can produce more videos and I can help you also with those in your studying. And I'll try to put videos every week. Next video will be obstetric examination. So first I'll take history examinations part, and then subsequently I'll move to case discussion or any labor chapters or like that only. I'll keep doing it. So thank you for watching me. Please subscribe, like and comment. Thank you.